Imagine that incredible sight, a brand new foal, all legs, trying to figure out how to stand, how to move. It's just pure wonder, isn't it? The start of a new life.
It really is amazing. So much potential.
But sometimes, beneath all that fragility and beauty, some of these little guys are facing a hidden battle right from day one, a heart condition they were born with.
Yeah, it's a tough start for some, unfortunately.
All right, let's get into it. Today's deep dive is all about congenital cardiac abnormalities in foals. We've looked through all the detailed info you sent us, and our goal here is really to pull out the key things you need to know.
I'd boil it down.
Exactly. Give you that shortcut to feeling well-informed. We'll cover, what these conditions actually are, how often they pop up, how vets figure them out, and importantly, what can be done. Get ready for, I think, some surprising stuff.
Definitely some counterintuitive things in there.
Okay, first things first. When we say congenital cardiac abnormalities, what does that actually mean in simple terms?
Well, essentially, these are structural problems. Malformations of the heart muscle or the valves that are there right from birth.
Born with it.
Right. Usually it's because something didn't quite develop correctly during that really complex embryonic stage. Or sometimes it's because parts of the fetal circulation, the way blood flows before birth, they fail to switch over properly after the foal is born. They stay open when they're supposed to close.
Okay, so how common is this? Are we talking rare or?
Looking at studies, particularly post-mortem exams on foals and fetuses, it shows up in about, say, 0.7 to 0.8%.
Less than 1% then?
Yeah, not hugely common, but significant. And if you look at all the birth defects found in foals, these heart issues make up around 3.5% of those.
And even though they're born with it, you might not notice right away.
That's right. The time it takes to actually spot the problem really varies. Depends a lot on how severe the defect is. Could be the first few weeks, could be months later.
Is there a genetic link? Like, do certain breeds get this more often?
There's definitely a suspected genetic component, yeah. Though pinning down the exact genes is still tricky. We do tend to see these abnormalities more often in breeds like Arabians, standardbreds, Welsh Mountain Ponies, possibly Morgan foals too.
Interesting.
And for one specific defect, the ventricular septal defect, or VSD, we'll talk more about that one, there seems to be a clearer genetic link in Arabians, standardbreds, and quarter horses.
But it affects colts and fillies equally.
Seems so, yeah. No obvious sex predilection.
It's fascinating, isn't it? Even with modern genetics, there's still these puzzles.
Absolutely. We know that breeds matter, but figuring out the precise why for each one, well, that keeps researchers busy. It really pushes us to understand those really early developmental steps better.
Okay, so before we get into the specific types of defects, you mentioned that fetal circulation, how the heart works before birth. That seems pretty key, right? Because some problems are literally the system not adapting.
Exactly. Understanding the fetal setup is crucial. It's really a masterpiece of temporary adaptation. See, in the womb, the lungs aren't breathing air, so they don't need much blood flow. The body has these amazing bypasses.
Like shortcuts.
Precisely. One really critical one is the ductus arteriosus. Think of it as a small vessel, a shunt, that connects the pulmonary artery, that's the one that would go to the lungs, directly to the aorta, the big artery going to the body.
So it just skips the lungs entirely.
Right. Bypasses them because they aren't inflated yet. Super efficient for life inside the mare.
Makes sense. So what happens or should happen at birth? Why does it become patent or a problem?
Okay, so at birth, the foal takes his first breath, the lungs inflate, and everything changes very quickly. There are pressure shifts inside the heart and vessels. Certain hormone-like substances called prostaglandins get inhibited, and the oxygen level in the blood shoots up.
Big change.
Huge. And all these things trigger that ductus arteriosus to start closing down. Now, it's normal to hear a little murmur from it in most foals for maybe the first 15 minutes, maybe even off and on for up to 3 days. That's okay.
But if it stays open longer?
Right. If it's still persistently open, still shunting blood after about 4 or 5 days, then we call it a pathological patent ductus arteriosus, or PDA. It's now a defect.
Got it. And there's another one you mentioned, the foramen oval.
Yes. Similar idea, different location. The foramen oval is a small flap-like opening between the two upper chambers of the heart, the right and left atria. Again, in the fetus, it lets blood bypass the lungs, shunting it directly from the right side to the left side of the heart.
And how does that one normally close?
Same trigger, basically. When the lungs expand and start working, the pressure in the lung blood vessels, the pulmonary vascular resistance, drops way down. This pressure change pushes that little flap closed. Usually functional closure happens within the first day or two, 24 to 48 hours.
But it might stay open if there are other problems.
Exactly. If the foal has high blood pressure in its lungs, what we call pulmonary hypertension, that can prevent the foramen ovale from closing improperly. It might remain patent or open.
So, okay, it's not just about holes forming incorrectly during development, but also these crucial fetal structures failing to, like, switch off after birth. That's a really helpful way to frame it.
Yeah, it covers two major mechanisms behind these congenital issues.
Right. So with that background, let's dig into the specific types of defects now, starting with the one you mentioned is most common.
Okay.
Ventricular septal defect, VSD, the classic hole in the heart. What's going on there?
Okay, so the ventricles are the two main pumping chambers at the bottom of the heart. The septum is the muscular wall between them. A VSD is simply a hole, or multiple holes sometimes, in that wall. It didn't fully close up during development.
And where do these holes usually happen?
They can be in different spots. Most commonly, they're high up in the septum, near where the aorta and pulmonary artery leave the heart. We call those paramembranous. Less often, they're lower down in the muscular part.
And what does that hole do to the blood flow?
Well, after birth, the pressure in the left ventricle is much higher than in the right. So blood naturally takes the path of least resistance and shunts or flows from the high-pressure left side through the hole into the lower-pressure right ventricle.
Okay.
And from the right ventricle, that extra blood then gets pumped into the pulmonary artery, heading towards the lungs. So you get more blood going to the lungs than normal.
Now, here's that really interesting point you mentioned earlier, the loudness of the murmur. Tell us about that again.
Yeah, this catches people out. With the VSD, generally a louder murmur often means a smaller defect.
Which sounds backwards.
It does, but think about water flowing through a pipe. If you have a tiny nozzle, the water sprays out with much more force and turbulence, right? Makes more noise. A big, wide opening lets the water flow more smoothly, quieter.
Ah, okay. High pressure, small hole equals noisy turbulence.
Exactly. So when a vet hears a really loud, roaring murmur from a suspected VSD, while it sounds dramatic, it might actually suggest the hole is small and potentially less problematic hemodynamically. A very soft murmur might indicate a much larger hole, allowing less turbulent flow, which could actually be more serious.
That's a critical diagnostic clue then. So what's the long-term impact of this extra blood flow from a VSD?
It causes what we call volume overload. The pulmonary artery, the left atrium receiving blood back from the lungs, and the left ventricle pumping it out, they all have to handle extra blood volume.
So they get overworked.
Precisely. Over time, this leads to the left ventricle especially getting thicker and larger. That's hypertrophy and dilation. If the VSD is really large, this can lead to left-sided congestive heart failure and also cause that pulmonary hypertension, the high blood pressure in the lungs we talked about.
And in some cases, both sides are affected.
Yes, if the hole is large enough that the pressure between the left and right ventricles starts to equalize, then the right ventricle also has to work much harder, leading to biventricular hypertrophy.
So what signs might you actually see in a foal with a VSD? What should someone look out for?
Well, if it's a small VSD, honestly, the foal might seem perfectly fine. The murmur might be the only sign.
Okay.
But with larger VSDs, the signs become more obvious. Things like poor growth, just not thriving like its buddies, getting tired easily, exercise intolerance, faster breathing, or difficulty breathing to tachypnea or dyspnea, maybe a cough. Poor appetite. Sometimes you can actually see the jugular vein pulsing in the neck, or it looks distended. And sometimes swelling or edema under the belly or in the legs.
And the murmur itself, you said it's heard throughout the beat.
Yeah, typically it's holosystolic, meaning you hear it right through the main contraction phase, the systole. Lobe shidub, lobe shidub. You can usually hear it on both sides of the chest, but the point where it's loudest, the point of maximal intensity, is usually on the right side.
Okay, clear. Now let's go back to the patent ductus arteriosus, the PDA, the fetal shortcut that didn't close. What does that look like after birth?
All right, so after birth, the pressure dynamics flip. Now, the aorta has higher pressure than the pulmonary artery. So if the ductus stays open, blood shunts the other way from the aorta into the pulmonary artery.
Still overloading the lungs then.
Exactly. Leads to volume overload of the pulmonary circulation and consequently the left atrium and left ventricle again. Very similar overload pattern to a VSD, just a different source.
And the sound is different.
Usually, yes. The classic PDA murmur is described as continuous or machinery-like because the pressure difference exists throughout the whole heart cycle, both contraction and relaxation. The shunting sound doesn't stop. It's often loudest high up on the left side of the chest, near the heart base.
And similar to VSDs, small ones might be asymptomatic.
Correct. Small PDAs might just have the murmur, but large ones will cause signs of congestive heart failure, similar to large VSDs.
Okay, now for a really complex one. Tetralogycephalate, TOF. You said it's 4 things wrong at once.
Yes, this one's a package deal, unfortunately, and usually quite severe. The tetralogy means 4 parts. You have 1, a ventricular septal defect, that hole between the ventricles.
Okay.
2, pulmonary stenosis, which is a narrowing at or near the pulmonary valve, making it hard for blood to get from the right ventricle to the lungs.
Right.
3, an overriding aorta. The aorta, instead of sitting squarely over the left ventricle, sits astride the VSD, receiving blood from both the left and right ventricles.
Wow.
And 4, because the right ventricle is pumping against that narrowed pulmonary outflow and often into the high-pressure aorta, it becomes very thick and muscular right ventricular hypertrophy.
That sounds really problematic. What's the main consequence of all that?
The big issue is often right-to-left shunting, because it's hard to pump blood into the narrowed pulmonary artery, and the aorta is right there over the VSD. Deoxygenated blood from the right ventricle gets shunted directly into the aorta and out to the body.
So the body isn't getting enough oxygen.
Precisely. And that leads to the most striking sign, cyanosis. The foal's gums, tongue, mucous membranes will have a bluish tinge because the blood isn't properly oxygenated.
What else would you see?
Severe exercise intolerance. These foals tire extremely easily. Weakness, maybe fainting spells, and just a general failure to thrive. It's a tough condition.
And the murmurs?
You typically hear a loud, harsh, holosystolic murmur, usually on the right side from the VSD, and often a systolic ejection murmur, kind of a swooshing sound during contraction, over the left heart base due to that pulmonary stenosis, the narrowing.
And the prognosis?
Generally poor, unfortunately. It's a very serious combination of defects. Sometimes there's even a 5th defect, an atrial septal defect, making it a pentalogy of a phallat.
Okay. Lastly, for the main types, atrial septal defect, ASD. Another hole, but this time upstairs.
That's right. An ASD is a hole in the wall, the septum, separating the 2 upper chambers, the left and right atria.
And the blood flow, left to right again.
Yes. Normally, pressure in the left atrium is a bit higher than the right, so blood shunts from left to right through the ASD. This leads to volume overload, but primarily of the right side of the heart, the right atrium and right ventricle.
Does it cause a murmur?
It can. Often it's a softer systolic ejection murmur heard over the pulmonic valve area because there's extra blood flowing through that valve. But small ASDs might be completely silent and cause no symptoms.
And how do these compare to VSDs in seriousness?
Generally, ASDs seem to be better tolerated in horses than VSDs of similar size. Large ones can eventually lead to right-sided heart failure, but often foals cope quite well, especially if the defect is small to moderate.
So it really depends on which part of the heart takes the hit, doesn't it?
Exactly. It comes down to the direction of the shunt. Is deoxygenated blood getting into the system? The volume of the shunt, how much extra work is involved, and which chambers are bearing the brunt of that extra work. Left-sided overload or cyanotic conditions tend to show up faster and more severely.
Makes sense. Now, besides those main ones, VSD, PDA, TOF, ASD, there are other rarer things that can go wrong too, right? Could you just briefly mention a few others?
Sure. They really showcase the complexity. You can have truncus arteriosus, where the main artery leaving the fetal heart fails to divide into the aorta and pulmonary artery. It stays as one big trunk, usually sitting over a large VSD. Very serious.
Okay.
There's tricuspid atresia, where the tricuspid valve between the right atrium and ventricle basically doesn't form. So blood can't get from the right atrium to the right ventricle normally. It has to shunt across an ASD or PFO.
Wow.
Pulmonary atresia, similar idea, but with the pulmonary valve missing or sealed shut off with the VSD. Then you can have narrowing stenosis, like subaortic stenosis, just below the aortic valve, obstructing flow out of the left ventricle. Or pulmonary stenosis, narrowing at the pulmonary valve, obstructing flow out of the right ventricle.
So blockages, essentially.
Right. And then the really complex plumbing mix-ups, like transposition of the great arteries, where the aorta comes off the right ventricle and the pulmonary artery off the left. 2 separate circuits, usually fatal unless there's a significant shunt, like a VSD or PDA, allowing some mixing.
That sounds incompatible with life.
Pretty much, without those shunts. And finally, you can just have badly formed valves, valvular dysplasia, causing them to leak regurgitation or be narrowed stenosis.
Okay, that's a lot of ways things can go wrong. So thinking about the owner, the vet, What are the key signs that should make someone think, maybe we should check this foal's art?
Well, the general signs we mentioned, just not doing well, poor growth, maybe lagging behind others, getting tired quickly during play, lethargy, weakness, not wanting to eat well, those are sort of non-specific but should raise a flag.
And on a vet's exam, the murmur is key.
The heart murmur is often the first specific clue, yeah. Especially if it's loud, say grade 3 out of 6 or higher. But and this is important, not hearing a murmur doesn't completely rule out a problem. Some significant defects could be surprisingly quiet.
Right, and you made that point about innocent murmurs versus problem murmurs.
Exactly. It's super common for newborn foals to have soft, physiological, or innocent murmurs for the first few days. They usually disappear on their own. The ones we worry about are louder, harsher sounding, maybe have that continuous quality like a PDA, or they persist beyond that first week, say 5, 7 days. Those need checking out.
And specific sounds point to specific problems, as we discuss.
Correct. That holosystolic murmur, loudest on the right, suggests VSD. The continuous machinery sound on the left points to PDA. The loud murmur, maybe with a palpable thrill, a vibration you can feel on the left, especially with cyanosis, makes you think TOF.
What other physical exam findings are important?
Definitely check the mucous membrane color for any cyanosis, that bluish tint. Listen carefully to the lungs for harsh sounds or signs of fluid. Check the breathing rate. Is it fast, tachypnea, or difficult dyspnea? Look at the jugular vein in the neck for distension or pulsation. Feel the pulses sometimes with things like PDA that can feel overly strong or bounding, and check for that ventral edema, the swelling underneath.
We touched on genetics, but what about other potential causes or risk factors? Things during pregnancy?
It's often hard to pinpoint. Suspected factors include exposure to teratogen substances that can cause birth defects early in pregnancy, maybe certain viral infections in the mare or periods of hypoxia, low oxygen affecting the developing fetus. Breed is definitely a risk factor, as we said, and being born prematurely might increase the risk of those fetal shunts like the PDA failing to close properly.
So a vet hears a suspicious murmur, sees some signs. How do they confirm what's actually going on inside the heart? Listening isn't enough, right?
No, auscultation, the listening part, is just the starting point. The absolute gold standard for diagnosis is echocardiography, cardiac ultrasound.
Echo.
Right? Echo lets us see the heart beating in real time. We can directly visualize the structures, identify the defect. Is it a hole? Where is it? How big? Is a valve narrowed? We can see the chambers, measure their size, assess how well the heart muscle is contracting.
And the blood flow?
Yes, using Doppler color, Doppler, and spectral Doppler, we can actually see the blood flow patterns. We can see the shunt through a VSD or PDA, measure the velocity of blood flow, estimate pressure differences. It's incredibly informative and absolutely essential for figuring out the severity and the prognosis.
You mentioned a bubble study, too.
Yeah, that's contrast echocardiography. We inject a little agitated saline, basically bubbly salt water, into a vein. If there's a right to left shunt, like sometimes seen with TOF or severe pulmonary hypertension with a PFO, we can literally watch those tiny bubbles cross from the right side of the heart to the left side on the ultrasound screen. Confirms the shunt direction.
Very cool. What other tests might be used?
Other diagnostics can add pieces to the puzzle. On ECG, electrocardiogram, looks at the heart's electrical activity. It can show arrhythmias, abnormal rhythms, or patterns suggesting certain chambers are enlarged. Chest x-rays, radiographs can give an overall picture of heart size, is it enlarged, cardiomegaly, and look at the lungs for signs of fluid, pulmonary edema, or changes in the pulmonary blood vessels.
What about blood tests?
Blood work can be helpful too. A CBC, complete blood count, might show anemia. Or, interestingly, sometimes in foals with chronic low oxygen from right to left shunts, the body tries to compensate by making more red blood cells. That's called polycythemia.
Too many red cells.
Right. Blood gas analysis directly measures oxygen levels. And there are specific cardiac biomarkers like NT-proBNP, hormones released when the heart muscle is stretched that can help gauge the severity of heart strain or failure.
And, of course, ruling other things out.
Absolutely. Need to differentiate from respiratory problems like pneumonia, which can also cause breathing issues, or those innocent murmurs, or even severe anemia causing a murmur.
Okay, so the diagnosis is made. Let's say it's a significant VSD or PDA. What happens next? What are the treatment options?
This is where things get, well, quite different from small animals or humans. The reality is surgical correction of congenital heart defects in foals is extremely rare. It's generally not considered a feasible option.
Really? Why not? People get heart surgery, dogs get PDAs closed.
It comes down to several factors. The size of the foal, even though they grow fast, makes intricate surgery very challenging, the complexity of many equine defects, and critically, there just aren't the specialized facilities and surgical teams widely available for equine open-heart surgery like there are in human or even canine medicine. It's a major limitation.
So no quick surgical fix, usually.
Not usually. There have been a very small number of cases, typically smaller PDAs, closed using catheter-based devices inserted through a blood vessel at highly specialized referral centers.
Yeah.
But it's definitely not common practice. It's technically demanding and expensive.
So if surgery is mostly off the table, what can vets do?
The focus shifts almost entirely to medical management. We're managing the symptoms and consequences, especially congestive heart failure, CHF, rather than fixing the underlying hole or narrowing.
What kinds of medications are used?
If there are signs of heart failure, we might use drugs like digoxin. It can help the heart muscle contract more strongly and help control a fast heart rate, but it has a narrow safety margin, so careful dosing and monitoring for toxicity are crucial.
Okay.
Diuretics, like furosemide, are very important. They help get rid of excess fluid, reducing lung congestion, pulmonary edema, and overall fluid overload.
Yeah.
But again, you have to monitor electrolytes like potassium as they can be depleted. And both drugs have situations where they shouldn't be used, contraindications.
Makes sense. What about just general care?
Supportive care is huge. Making sure the foal is getting enough oxygen, sometimes supplemental oxygen might be needed. Managing exercise, restricting activity to reduce strain on the heart. And nutrition is critical. These foals need calories to grow, but might have poor appetites or tire easily when nursing. Sometimes nasogastric tube feeding is necessary to get enough nutrition into them.
What if the defect is mild, like a small VSD or that PDA that might close?
Then observation is the approach. For those innocent physiological murmurs or PDAs in the first few days, you just wait and re-listen. Many small PDAs will close on their own within that first week. Even small VSDs can sometimes get smaller or close over the first year of life.
So monitoring is key.
Absolutely. Regular rechecks, usually including repeat echocardiograms, are vital to see if things are improving, staying the same, or getting worse.
Okay, let's talk prognosis. With all this variability, what's the likely outcome?
It really runs the gamut. It depends heavily on the specific defect, how big it is, how much it's affecting blood flow and heart function, what we call the hemodynamic significance, and whether complications like CHF or severe pulmonary hypertension have developed.
So who does well?
Foals, with those small hemodynamically insignificant VSDs, often have an excellent prognosis.
Yeah.
If the murmur is the only sign and the echo shows the heart isn't stressed, they can live perfectly normal lives. Some even become successful athletes. The same goes for a PDA that closes spontaneously in the first few days. Excellent prognosis.
And the other end of the spectrum.
Large VSDs or large PDAs that have already caused congestive heart failure or significant pulmonary hypertension. Their prognosis is much more guarded to poor. Medical management might help them feel better for a while, improve quality of life, but it usually doesn't stop the underlying disease from progressing.
And the complex ones, like TOF.
Complex defects like tetralogy of Fallot, transposition, severe atresias, they generally carry a very poor prognosis. Sadly, many are incompatible with life beyond the first few weeks or months, even with medical support.
What about preventing this? Can anything be done?
Since there's likely a heritable component to many of these defects, the main recommendation is not to breed animals that are affected, or potentially those known to produce affected foals to try and reduce the incidence.
And long-term monitoring for those that survive with smaller defects.
Yes, even foals with small VSDs that seem fine should probably have yearly checkups, ideally including an echo. We want to watch for any late-onset signs of trouble, like developing CHF or an arrhythmia like atrial fibrillation, AFib.
What are the signs of AFib?
That might show up as sudden exercise intolerance, coughing, difficulty breathing, lethargy. For moderate to large VSDs that are being managed, sometimes an ECG recorded during exercise can help assess risk.
Ultimately, it sounds like quality of life is the main goal for many.
For the severe, untreatable cases, absolutely. The primary goal becomes maintaining good quality of life for as long as possible. And difficult as it is, euthanasia has to be considered if the foal develops unmanageable heart failure or has poor welfare despite treatment.
Wow. Okay. So we've covered a lot of ground here, from how these full heart problems start, sometimes even before birth, to the specific defects, how vets diagnose them, and the often challenging realities of treatment and prognosis. It's really quite something.
It is, and I think studying these conditions, even though they're specific to foals, really gives you a deeper appreciation for just how intricate normal development is. The body's ability to build this complex organ and then completely reroute the circulation at birth. It's incredible when it works.
Yeah, and seeing what happens when it doesn't quite go right teaches us a lot.
Definitely. It highlights critical developmental pathways and physiological switches.
Which brings us to a final thought for you, our listener. We've talked about genetics, breed risks, those crucial changes right at birth. How might digging deeper into these processes in foals, understanding why these specific defects happen, actually unlock bigger biological secrets? Could it hold clues for therapies, maybe even across different species, including humans? Something to think about.
A really interesting question to ponder.
We really hope you found this deep dive valuable. If you've got a topic, maybe some sources you want us to tackle, definitely send them our way.
Yeah, we'd love to hear from you.
Until next time, keep digging into those fascinating facts.